I'm Arvind Kasthuri. I had a little more hair in that picture that you saw earlier. And I do deserve your sympathy because even in the morning, Dr. Rajgopal spoke before me, which recalls a story. Apparently, George Bernard Shaw was invited to speak at a function in Edinburgh. And he went to his train, ascended his carriage, and to his shock, he found that Winston Churchill was also seated in the same carriage. Not enough, Churchill told him that he was also going to the same function and speaking at the same program. So they went, they reached, and Churchill spoke first, beautifully, thunderous applause. And then Shaw went up, and he said, "The gentleman who spoke before me and I traveled together in the same carriage, in the same compartment. To pass time, we exchanged each other's speeches. We read each other's speeches. He read mine, I lost his." So, with that, thank you, sir, for that wonderful. This morning also, Dr. Rajgopal was brilliant. Every time I've had the opportunity of meeting him once before this in Kerala, and it was absolutely lovely. Thank you, sir. Well, ladies and gentlemen, on with the mission. This is what I thought that I would share. Some thoughts on this group of people aged 60 years and above, which the Indian government calls elderly or senior citizen. We are on the threshold of the World Health Day, April 7th. So, on the threshold of the World Health Day, and this graphic shows you, I just put this graphic up to show you, to remind us all that in the year 2050, there is a demographic phenomenon which is poised to happen, which has never happened before, which is the population of elders will actually exceed the population aged 0 to 15. That's actually quite a demographic thing if you think about it. The senior citizen population will actually outnumber the child population for the first time in recorded history in 2050. Probably which is what prompted the WHO to declare that this decade, 21 to 30, is the decade of healthy aging. So I thought that I would outline what I have to say with one eye on the clock on these headings. I thought that I would start with sharing some demographics with you about this population. Then talk about a few challenges which we recognize as those working in primary care with elderly populations. A few words about some of the things the state is doing for the senior citizen population. And then end by sharing a few words about our journey in St. John's with a primary care program for the elderly. So let me go on. There are a few things that we know about the elderly population. One, it is large. Even the document circulated to us, the graphic, says that we have almost 150 million people aged 60 years and above. Millions roll off our lips in India very smoothly, no doubt. But if you consider this number, it's actually more than the combined populations of the UK, Australia, and a few sundry European, you can throw a few European countries into the mix. And that's their entire population. And this is the population of senior citizens that we have in this country. Not just large, that population is growing. Now, the proportion of people aged 60 years and above in this country now is about 10 to 11%. And it is poised to rise to 20-odd% by the year 2050, which means every fifth Indian is a senior citizen at that point. Now, many Western countries have actually reached and have exceeded this as well. And we are heading there. I mean, we are actually going. We can see it's coming, and we're just heading there, right? Like one of the WHO directors once famously said, Director Generals once famously said, the Western population grew rich and then old. Our populations are growing old and probably then rich. Right? So our demographics are heading towards this point inexorably. And And whenever I put this up to some medical students and I say, why do you think this is happening? And I fix the eye on them. And I can see frantically, do older people reproduce to other older people? How is this happening? Kind of. So the fact of the matter is that we know life expectancy is going up and the fertility rates are actually falling. When we were medical students, I'm sure Dr. Rajgopal also would recollect his old medical student days when we were talking about fertility rate and something called the net reproduction rate. In public health, these are measures of the reproductive ability of the population. We have finally reached what we call replacement fertility. So in other words, people are having less children, and those children are growing and staying old for longer, right, when they do grow old. And these are the demographic causes for why our older population is actually rising. Still, most of our elders live in the rural areas. This is a 2011 graphic. The tragedy is that we do not have a census after the year 2011. But even now, the proportion is about 70% of our elders are rural. And 70% of 1.4 billion people is what we are talking about. So I think that that's a very powerful message there, that still we are a rural country, really. Despite shining 100 feet road or whatever it is, we still are mostly there. This is another thing which is rising, which is the dependency ratio, which is the number of older people per 100 persons in the working age group or in the middle ages. And that is also, that we call that the old age dependency ratio, and that's also climbing. And a phenomenon that is happening is also what we call feminization of the older population. One is, of course, the older woman's life expectancy is a little higher than the older man, and that's what this graphic shows. But this is another very sobering thought. Among older men, 15% are single. Among older women, 48 to 50% are single. Just think about that. I mean, woman, man, they keep going, and then this guy drops off. And so the single elderly woman is a demographic group which deserves attention at primary care. And that is what I'm trying to point out here. Healthcare, of course, since we are from a healthcare institution, the health of this population is also something that is very sobering to look at. Obviously, we know that the number of conditions, chronic conditions, rises with age. But if you look at the prevalences of acute chronic morbidity, and like what Dr. Rajgopal said, psychological distress, what is between the years, is the prevalences are high enough for us to really think about what are we doing as far as this group is concerned, right? So, when we considered a healthcare program for the elderly, we were very, these challenges that I'm about to say, what I call the 5 A's, were brought home to us quite forcibly. First is the challenge of access. Now, how many older people have access to healthcare when they need it? Or like Sir said, where they need it, when they need it, right? It could be geographic access, which is there a healthcare facility close by enough for an older person? It could be physical access, which is how many of our older persons are actually able to go or are mobile enough, or are they confined to their homes? And even that population of 60 and above is by no means a homogeneous group. We all know that the 60 to 70 are as sprightly as anybody else. In fact, there are 69 and 70-year-olds who are extremely cheerful and are the life and soul of the party, and there are 55-year-olds who look like the world is on their shoulders. So heterogeneity is inherent in the older population. But among that 60 plus are the groups 75 and above, 80 and above, and 85 and above, which are very fast growing demographic segments in our population. And those do merit our attention. And not just these accesses, but also transport and social access. How do I get there? Okay, it is close by, but I can't just get up and go. When a person is younger, you have a cold, you just go and see somebody. You don't think twice about it. But when we are talking about an 85-year-old with a health problem, that person can't just get up and go. Transport, who will take him or her there? A social access issue and other determinants, of course, the older woman, like we said, caste and social class. Let me not get started on those things. I think that is bringing a coal to Newcastle as far as Azim Premji University is concerned. I know that you all discuss things like this quite vigorously. The second A is awareness. And when we talk about health literacy, we mean, what is this? The ability of individuals and communities to actually use information and services about their own health. And how many of our elders actually have the health literacy that they need? And what, as a healthcare professional, am I doing about that? Is the question really that we need to ask when we say awareness, access, awareness. And of course, in our country, this always has to figure. We are waiting for our public health expenditure to reach 2.5% of GDP. And that's not a tall ask. I mean, there are countries which spend 5%, 6% of their GDP on health. We are still crawling at 1.9%, and we clap loudly at our budget presentations. More than 50% of all expenditure on health is in the private sector. Though we are supposed to be a country where a right to health is enshrined in our statute, right? And catastrophic health expenditure, which Dr. Rajgopal already spoke about, occurs in a large percentage of our households. And of course, D is fairly obvious. The older you get, the more is likely to be your healthcare expenditure, and the less likely you are to be able to afford that expenditure. I often talk to my students about a small black book which I have in my pocket, where I've written the questions that I'm going to ask this guy when I go up there. Why is it that when our abilities are the least, our needs are the most? I mean, that's a question for him, not for you. Or her, sorry. Fourth is what I call the absence phenomenon. So we motivate our older population to actually seek healthcare when they need to. And so a guy goes to the primary health center and he finds there's nobody there. Right? Out of a total of so many sub-centers, so many lacked a female health worker and that many lacked a male health worker. I often say it's easier to spot the Indian tiger than the Indian male health worker. I mean, it's a kind of an endangered species which is growing smaller and smaller as we speak. And the vacancies in the government sector is also a matter of huge concern. And the fifth A is this. This is really an ethical issue. What is this accountability? Who is the health worker accountable to in his dealings with, I say elderly client, but actually with any client? He is responsible. He is accountable for his professional competence. Like Dr. Rajgopal said, competence goes hand in hand with compassion. It is not enough to have just one, but you need to know what to do and then do it with compassion. And that's the professional competence accountability. He is accountable for his conduct or her conduct. He is accountable for ultimately doing something which will be of benefit to the larger community, to ensure that whatever he does is lowering that barrier of access, promote health at all times, and keep an eye, not on the clock, but on the purse. Now, that's another big gap in our training of medical students. The first time a medical student knows about the cost of things is when he's an intern, perhaps. Because the stray patient comes back and says, "Idnam kaina lagala, bere nadon barkodi." It's too costly. I write something else. That is when it says, "Oh, costly." Is it? "Oh, yeah, there is." Right. Medicines cost. No, yeah, kind of a thing. So I think that the way in which we are training our medical students is, let me not get started on that. So these are what I call the 5 A's, which are kind of challenges to healthcare at the primary level, specifically for older persons. Okay, this is what are some of the things that our state has done for the senior citizen population, many of which you probably know, so I'll not kind of read the whole thing. But support to NGOs, higher interest on fixed deposits, income tax exemption limits, concessions on air travel, LIC, and of course this MWPSC Act, which is Maintenance and Welfare of Patients and Senior Citizens Act, is a law which mandates that the children are supposed to take care of their parents in this country. But how many parents are actually going there and pulling their child into a court of law is another question altogether. The family name is at stake, so to speak. And food security with the Annapurna scheme. The only problem is this is from the LASI, or the Longitudinal Aging Study in India, which showed that the proportion of people who actually knew about these schemes was not a very healthy proportion. That's the proportion all India who knows about concessions given by government for senior citizens. And we desperately need to build the awareness even about those existing schemes. In the healthcare area, we have now the National Program for Healthcare of the Elderly, or the NPHCE. Again, very well devised, from a domiciliary level at primary care to a sub-center, to a primary health center, to a district hospital. What should each level do has been enshrined very well. But then if you go to a given primary health center and says, when is your geriatric clinic? It's supposed to be every week. Is what the answer you will get, probably. Because the implementation of these programs is still nowhere near where it should be. So now, yes, all that said, but I strongly believe that, yes, I mean, one doesn't have to look far in India to see what should not be happening. But that doesn't mean we lose hope and we don't do anything. So I think that we must do whatever we can in our areas, and that's what made us start this thing. Long ago, not in a place far, far away, it's only 30 kilometers away, in our rural area, we, in the late 1990s to the beginning of the millennium, the first decade, I joined St. John's in 1993. And the first 7-8 years of our work in the rural area was largely to do with the health of women and children, because that was the need of the hour. But as the millennium changed, chronic disease and non-communicable disease started to take center stage. And it was then that our eyes fell on this. This is a gentleman sitting opposite our rural health center, looking after his goat, which is there in that corner. And we realized that, we called him into the center and realized that when we checked and asked him, again, BP, sugar, and didiya, do you have BP or sugar? He didn't know, quite frankly. And so we checked, and then we found that, hey, what about this constituency of people who are the rural elderly? Can we do something for them? So we went ahead. A lot of discussions happened, and in a typical public health department, a lot of banging of the table. No, that is not what we should. All that happened. We said, let's do a situational analysis. So we got hold of a tool to do it. And I remember going and meeting this gentleman, Professor Ramaswamy. Some of you may kind of recognize that figure, one of the founding directors of Indian Institute of Management, Bangalore. He was working in Koramangala in Cartman. That's one of the NGOs there which look after animal welfare. And he was running a small place called the India Heritage Academy. It's still there. And so a colleague of mine and I went to him and we said, we want to work with this. We've got these ideas and this and that. He listened for about 5 minutes. And then he said, Doctor, I think you need 2 things. You need a table and a chair. Just sit here and start. So we said yes. We went home chastened and said, let's start. And the first rural geriatric clinic we began in our rural health center in the year 2003. Gradually, we expanded to more village sites. We christened it the Senior Citizen Health Service, inaugurated it, and then added a few more components. We registered older people living around St. John's, and a doctor and a nurse make a visit to them at home once a month. We call that the home health service. We added old age, 3 or 4 destitute old age homes. Our team visits once a month. All this was added to our senior citizen health service. And then we started another clinic in an urban underprivileged area and opened a geriatric clinic in the hospital also, in St. John's Hospital. Then in 2015, Tata Trusts called us to brainstorm with them, and out of that came the idea of what we call the Grama Hiriyara Kendra, or the Village Senior Center, which is very much like an Anganwadi Kendra, if you know what that is, a creche for children, but for older people. They come in the morning, they stay there during the day, they begin with some physical activity, bhajan, then of course gossip for about 2 or 3 hours about each other's kashta sukha, and then go back in the afternoon. But it is a place where people get together, and rather than, like was mentioned, loneliness and insecurity. These are 2 big issues which I think we recognize at primary care with older people. Loneliness, there is nobody here. Insecurity, what if something were to happen to me? So these are small steps to try to deal with those issues. And then was when we went to our governing board in 2020 with the concept of what we thought would be a center for older people on the campus of St. John's. And after that, we actually today have what we call the St. John's Geriatric Centre. It's come up, but it hasn't started functioning yet. Hopefully, towards the end of this month, we will start seeing our first few patients, admitting them there and seeing what best we can do for this population. And 2 floors of this center, sir, are dedicated to palliative and hospice care. So it is also serving that function along with our Department of Palliative Medicine. So it serves 4 functions. Care, of course, in those 150 beds across the center. Training of all cadres of people who look after older people. It could be home health nurses, staff nurses, anybody. Community engagement with elders and their caregivers. We recognize the caregivers are a very, very important constituency, like Dr. Rajgopal was saying. And we need to engage with them to relieve their burden and think of them and what are they doing. So it is to promote wellness, that community engagement activities, and of course, research on aging and geriatrics. So this is what I had for you. Oh, so I've exceeded by about 2 or 3 minutes, I'm sorry. Today, in summary, this is what I had to say. I guess we'll keep the rest for the questions and answers which follow. Thank you very much.